Thank you to Margaret and all at the BLS for inviting me to deliver this session today. Day to day, one of our biggest challenges as clinicians and those living with lymphedema is working with compression. I still work in clinical practice as part of the team at Oxford Lymphedema Practice and Lymphatic Therapy Solutions and see this on a daily basis. It is a huge burden for our patients who have to wear compression, sometimes 24 hours per day. In clinical practice, we often feel that we lose sight of what's available as there's just so much out there. We have to remember that we have a duty to stay up to date with not only what is available, but understand that this is never a one product works for all. As part of Lymphedema Awareness Week 2025, I'm going to spend the next few minutes revisiting the types of compression that are available for managing lymphedema, as well as considerations for selecting compression therapy. For those of you living with lymphedema, this will help you get the best out of working with compression as part of your ongoing management. And for our clinicians watching, hopefully you will take away some tips to ensure that your patients have the right treatment for them. So what is compression? We have to go back to this when we consider what compression is. And basically, when you look at a definition of compression, it is the application of an applied force to a solid, gas, or liquid so that it takes up less space. For us, it's the mainstay of treatment in venous and lymphatic disease. And when we relate this to the management of lymphedema, the compression reduces the amount of edema that is basically sat in the tissues. The action is very dependent on the force, so the pressure applied, and the type of compression used, as well as the material properties of that compression. It can improve blood flow back to the heart because it is graduated. It ensures that there is more pressure on the distal aspect of the limb. So in the case of a leg garment, the most pressure at the ankle, graduating off as it reduces up the leg. And the same for arms, this tends to be at the wrist. And this helps to move that fluid out of the tissues, but also increase the return of that blood to the heart by supporting the vessels, the veins, and the muscles to help fluid move. There are many types of compression available, from garments to hosiery to bandages to adjustable wraps, and our choice of treatment will very much depend on what the goal of the treatment is. If we want to reduce, or our patient wants us to reduce their limb, then we may use a bandage or an adjustable wrap before measuring and fitting for a compression garment to help maintain that reduction that we've achieved. Garments differ. However, it is widely accepted that the most commonly used are either circular knit or flat knit, although there are other materials available. Circular knit garments are knitted on a cylinder, and this means that they have a constant needle count, allowing for a variable mesh size. And the way I always explain this is that when you compare a circular knit garment, it's very much like opaque tights. As you pop those tights on, you can see that more of the skin as they stretch. So they will look darker on the ankle, but look a little bit lighter when you get up to the thigh. And this is because the variable mesh size, so that mesh will stretch. Circular knit garments tend to have a sizing chart, although there are products available in circular knit that are custom made, but the majority will have a sizing chart. So you select the appropriate size for your patient or for yourself. Now, flat knit garments differ because they are knitted on a flatbed machine and then stitched together. Although there are forms of flat knit garments that are seamless and they are knitted slightly differently, but still on a flat knit machine. They tend to have a seam down the back of the garment or on the side. You can sort of select where you want seams, but are mostly made as custom made garments. So you will measure and complete a custom made form so that you've got specific measurements for both lengths and circumferences, and then we will make the garment, or the company will make the garment to the measurements that you have requested. They tend to have a fixed mesh size. So the thing with flat knit garments is they sit quite firmly on the skin and they don't stretch as the limb gets larger. The mesh size remains the same, and this holds the limb much better. There are other compression products, such as those used for midline swelling, including bras and shorts, which use high-grade breathable paranit fabrics and are manufactured using cut and sew methods. So there's a pattern, they are made to a pattern and then stitched together. And then last but not least, we do have nighttime garments, which again are different to our traditional flat and circular knit garments, and do provide a lower pressure for when resting. So many different types of compression out there. The other thing that we should all be aware of is our compression classes, and they can be equally confusing, especially when working with different companies, because different companies will work off different standards. Here just shows some general standards that compression could be made to. This is not a full list, but details some of the most common standards in the UK. And you will see that when we mention a class 1, 2, or 3, this can very much differ depending on what standard is used. Attempts have been made by various organisations to simplify this further into categories of what would be classed as mild, moderate, high, and very high level of compression. But even when using these terms, we must always detail the level of compression in millimetres of mercury so that we understand what dose of compression is working for our patients, or as a patient, what dose of compression works for you. As you will see, the pressures differ between the standards. So what may be very high in a, say, RAL or American standard is actually in the high zone as a French standard. So it's really important that we get to know those pressures. So I've been having a big think about how do we win with compression? And I think the biggest thing for me as a clinician, that it always goes back to assessment. It's very important. And with all these products available and all the compression classes, how do we decide? We should revisit our test assessment, and our choice of compression will depend on this and the goals that we set in partnership with our patient, or rather, the goals our patient sets in partnership with us. It not only considers our physical assessment, but our patient reported symptoms. Our physical assessment can take many forms, with palpation, visual inspection, and limb measurements, as well as other measurements using things such as bioimpedance or lymph scanners to assess fluid levels. As a clinician, I will ask the patient to complete validated quality of life tools to ascertain symptoms and how that swelling behaves throughout the day. This allows us to set goals, and really important aspects such as what makes the swelling worse or better, what level of exercise are you doing, how does it impact your ability to find clothes and shoes to fit, and how does it impact how you feel about yourself. We must consider all aspects as a whole. If we have a minimum limb volume difference, usually dominant to non-dominant limb volumes are slightly different, with no visible signs of swelling, and our patient reports discomfort or feelings of heaviness, should we opt for compression straight away? I would argue we shouldn't. I would argue that we should send for further assessment, and this will become clearer because compression does not reduce the risk of lymphedema developing, and this is very clear in the NICE guidelines. And this is a very busy slide, I know, but I wanted to get points across is that actually we're subjecting our patients to lifelong compression in instances where it's not needed. Now, although not widely available, so mainly in the private sector, there is access to other forms of diagnostic tests, and we should be making our patients aware of the use of ICG imaging in the diagnosis of lymphedema. This can show us if the lymphatics are functioning or if it matches the functioning matches the symptoms that the patient's experiencing. These are some of the images that are taken from the reference on the screen and the Oxford Lymphedema practice talk through with the patients when they come in for an assessment. And it's very much looking at the functioning of those lymphatic vessels and how looking at them under a microscope has shown how you go from normal to a vessel that over time deteriorates and can become sclerotic, and how this relates to the different stages of lymphedema. When patients are injected with indocyanine green into the web space of the fingers or the toes, and a PDE camera is shone on that limb, you get these images, these black and white images that you can see on the screen here, which can show clearly whether there are, again, functioning lymphatics, lots of collecting vessels, as you can see in the bottom right hand images, or those images that we'll see where there is a minimal disruption to the lymphatic function or quite an extensive disruption where we don't see any of those nice channels. And it can also allow us to assess that how is that vessel functioning. So is drainage through that vessel going the correct way, or is there a problem with the valves that mean that you are getting reverse flow through those collecting vessels? It enables a more accurate diagnosis rather than just opting for straight compression, and quite often is used in conjunction with other imaging methods such as lymphoscintigraphy, which can tell us about the deeper lymphatic function, and MRI sequencing, which can look at the proportion of fluid to fat within the limb. There are instances where patients have visited our clinic and have not had lymphedema. They've had that bottom image where you've got clear, visible lymphatics, no areas of what we call dermal rerouting or dermal backflow, yet they've been advised to wear a sleeve and not do certain forms of exercise and other risk reducing behaviours, which have no robust data to support them. And so it is, again, very, very important that we get our diagnosis right, because compression is a huge burden for that patient. So having been able to say to a few patients, right, take off the compression because there is no swelling and you are at risk, but you have got no evidence of lymphedema in that limb. However, on the flip side, there are groups of patients who do present with lymphedema, but for one reason or another, it's not being managed. And this can be due to several factors, such as the compression is not being reviewed as often as necessary, or as patients, sometimes you feel you don't want to bother the lymphedema clinics when you're having issues with your compression. So you are not letting us know that there's an issue. I would always say, please do let us know that there's an issue. And I know that there is some challenges with getting appointments at times, depending on services and how much service provision there is in the area, but making sure you get some advice from somebody if compression is not fitting is really, really important. Um, in the case of this patient, you this patient was wearing a garment, but that garment was too big. Um, and each time that some patients will go back, the limb size will have increased slightly. They will then get ordered a garment to fit the limb at the size it is now. So you get this gradual increase of a half a centimetre, a centimetre over time, and it just allows the limb to grow into garments rather than thinking, oh, this limb is getting slightly bigger. What can we do to, firstly, if this limb is getting slightly bigger, then we need to review our compression and our choice of compression and what is being done. And that's on in both aspects. So discussing with the patient um, how often they're wearing their compression. And for us, looking at, okay, do I need to increase a compression class or look at using a different fabric? We will use MRI imaging. And this MRI image here is of a patient who has consented to allow us to use these pictures, who presented to Oxford with extensive pitting of the foot and calf. Pitting shows us that actually there's quite a high fluid content, but with minimal pitting to the upper thigh. Her lymphedema was secondary to gynae cancer treatment, and she was in a class 3, so a 34 to 46 millimetre of mercury flat knit garment. But this flat knit garment was really loose, and it was loose because it was actually very easy to get on. So that tells you that it's quite loose. Garments should be easy to get on, but not that easy that they just slide on straight away, and actually you need to get the muscles working. Her excess limb volume, so the limb volume size of the affected leg was 86% bigger than her unaffected leg. So these images here, you can see that actually the full leg image is within there. There is a mix of, that image shows quite a lot of fluid in the lower leg and less fluid in the thigh. The smaller top hand images on the right, that is representative of fluid, but then on the left, it's representative of fat. So it gives us a good, clear indication of how much fluid and how much fat is in there. So what did we do? Well, we made recommendations just to use an adjustable wrap on top of the current garments during the day, and an adjustable wrap on top of her night garments for a period of 6 to 8 weeks. And this was due to the fact that there was minimal access to be able to get decongestive treatment through a local service. Again, very much due to demands on services that we see throughout the globe, really. So she was unable to access bandaging. So she did this for a period of 8 weeks. And after 8 weeks, she came and had another MRI scan and was reassessed. Measurements using the pyrometer. And the images show the difference in her limb pre and post treatment. So you can see the pre-treatment, post-treatment, that actually the middle of the leg, so down the center of the leg, that there is much less fluid. It's quite a lot of fat there, but we do still have some fluid remaining on the outside. And again, those deeper, small cross sections of those MRI scans show that you've got a reduction in fluid, but there's still quite a bit of fat. She was able to reduce her limb down to 57%. And the remaining volume, although some fluid, there was hardly any pitting. So this indicates that actually there was quite a lot of fat, and she opted to have liposuction. But from that, you can just see that those small tweaks to compression and the use of layering of garments is really good for those patients. Complications. So you can see that the wrongly selected garment or bandage application can result in edema being pushed to other areas of the body, as so shown in the first and second images. We must consider this when we're selecting compression. What is the likelihood of this occurring, and how often should we review to monitor this? When medication's prescribed, this will often get reviewed. So why not compression? As a patient, if you experience any increase in swelling to an area not covered by compression, it's really important that you contact the person that prescribed your compression. The same applies to hosiery that is cutting in, and I said this previously. We do not advise that you cut your garments, but seek professional help and work with your lymphedema practitioner to find suitable solutions. Or if it's not a lymphedema practitioner that's prescribed your garments, whoever prescribed them. You can see on the third image that this patient has cut the garments because they are cutting in. And in this instance, it's actually this patient should really have had a flat knit garment rather than a circular knit. In the middle image, you can see where that fluid has been pushed up to above knee. And again, we would look at the possibilities of layering garments. So this patient had some capri style tights combined with some below knee garments, which meant that it was easier for her to get them on, and that actually lifted and reduced those thighs. The other things to remember is that ill-fitting hosiery can lead to skin damage and an increased risk of infection, a lack of confidence in compression as a treatment modality, with patients often saying that they've tried compression before, it hurt them, it doesn't suit them, or their condition, symptoms, or lifestyle. And it's that thing of we do have to consider that. Furthermore, poor management of lymphedema leads to worsening symptoms and worsening lymphatic function. So going back to those slides where it showed the actual sclerosis of the lymphatics, although if it's going to occur, it will occur. But actually, we have to remember that the inflammatory nature of lymphedema and that inflammation in itself prolonged inflammation can lead to tissue changes, poor limb shape, and increase in size of the fat cells. So it also puts patients at risk of repeated episodes of infection. So really getting that management um, is key. So how do we achieve success? Oh, it's a big question, that is. I think the most important thing we can do is listen to our patients. If the garment is uncomfortable, cutting in, or the edema is getting worse, then reassess. Don't be afraid to change what you are doing. If you are unsure, then or unsure, contact your peers, local networking groups, or remember that most of the companies have groups of clinicians that will be there to advise you. What I would say is don't leave them. Don't think, oh, okay, we'll put them back in that compression and then monitor. If the limb volume or symptoms are worsening in the compression that the patient is in, then we have to change it. I do acknowledge that there are instances where we have tried several different methods, styles, and types of compression, which has a financial burden. We are restricted by our budgets, and there has to come a point where we need to look at, okay, is compression the right treatment modality for this patient? It's at this point that we must try and spend time revisiting our patient goals, use of compression, and views on management of their lymphedema. And in many instances, when I go back and review this tends to lead to us making referrals for psychological support, because it goes back to it's such a difficult thing to accept or to live with. And we must really, I am not qualified to support my patient's psychological needs. So I will refer out to those people that are, to ensure that my patients get the best that they can. It will then allow them to have some tools that try and make it a little bit easier for management. Even more important as well is that education. Again, educating patients to understand what is going on in their body with respect to their lymphedema. And we do this in individualized, appropriate ways. So these would be the things that would look at for me how to achieve success. And bearing in mind that actually, in some instances, it's not about the compression, it's about success in everything else and what is important to that patient. Individualize the care. I think the biggest thing for me is that you go back to a lots of the best practice guidelines and looking at the levels of compression that can be used. It's not just about level of compressions, it's about different products and what different products do. But the layering of different compression products allows us to achieve high to very high levels of compression, especially where edema is prone to refilling. Sometimes this is not just due to needing a higher millimeters of mercury pressure, but having more layers will increase the firmness or stiffness of the garment on the limb. This should not be done without monitoring from healthcare professionals, though. So, for patients watching this, please don't just go off and start layering your garments. You must discuss this first and see if it's appropriate. We should recognise that none of us wear the same type of footwear or clothes every day. So why would we wear the same type of compression garment? I would not run a marathon, not that I've ever ran a marathon, in jeans and ankle boots, or ride a bike in a pencil skirt with high heels. We have to bear this in mind. We should titrate the compression based on lifestyle. If running a marathon is important to that patient, then it may not be feasible to do that in full compression tights that may have been prescribed. It may be more comfortable to wear a thigh length garment. The same goes for cycling. Having a compression garment that allows us free movement with the repetitive bending and extending, using a garment of a lesser class whilst exercising, and then stepping up into a stronger class post exercise. So, quite often, I'll have patients that will use different compression for exercising and then step back up and into a stronger level of compression once they've finished. So we have to ensure that to do that, the patients have the right level of education tailored to enable them to titrate their compression based on their daily life. Ultimately, it helps to empower people and helps people to feel confident. And they will be the best person to know that if their swelling is increasing or the skin condition is worsening, and that the current compression regime is not effective. So those were just some of the things that I'd consider, but it's really, again, very important for us, especially as part of Lymphedema Awareness Week and throughout the year, to access the information out there for clinicians and for patients. And there is lots available from the BLS website, resource pages. Patients can also link in with patient organisations such as the LSN, Lymph United, and Lymphoedema. Most of the compression companies as well will provide CPD accredited education, which is evidence based and is underpinned by best practice guidelines. Most importantly, delivered by clinicians who are experienced in the use of compression and the management of lymphedema. So those are just some general tips to try and help improve outcomes with compression. And I really appreciate you taking the time to listen to this session. And I hope that Lymphedema Awareness Week is a huge success and in raising the awareness that's needed. I look forward to chatting through some questions when they're available. Thank you.
Thanks very much, Natalie. That was really a quite a lot of information and there's lots of interesting questions. But I think one thing you did do is really highlight how important it is for a patient-centred approach and to work together, patients and professionals, because everybody's different. There's so many different ways to approach it to suit patients and get the best possible outcome. So there are, say, interesting questions.
Yes.
Some of them are quite personal, but let me ask first what was from an earlier question about how effective is compression?
I think when you get it right, and when I say get it right, when the patient has access to products that are suitable for them throughout everyday life, it is very effective. Um, and we have to remember that actually it's about containment. And once we've got that reduction, if somebody's edema is not being contained, then they're not in the right compression.
Okay, thanks very much. I'm going to pick up some of the more personal ones because although they probably to see somebody, you might be able to give them some tips. So one was about, can compression cause damage or encourage cancer to return? And this was from a person who has been wearing compression for breast cancer-related lymphedema for 2 years, but it's gone from severe to moderate and it's now back to being more severe.
Okay, firstly, I'd say that compression doesn't cause cancer to return. That is a pathological process in itself, so compression won't cause it to return. Again, if that edema is not reducing and you're doing using lots of different tools, so it might not just be the compression, particularly in chest and breast swelling, we do focus quite a lot on the use of lymphatic drainage techniques. So it may be that, again, it's that titrating of compression and your other modalities to try and reduce it again and then find something appropriate to maintain it. I think the one thing that we all know is that lymphedema is not static. Goes up, it comes down, it goes up. So it's you feeling empowered to be able to say, okay, it's gone up today, I'm going to do this. But tomorrow it's gone down, so I'm going to do this. And it's so individual. So I just can't say to people enough, if you've got issues or you feel that it's not behaving, to speak to your therapist, definitely.
Okay, thanks, Natalie. Another one is about if someone has upper or lower limb paralysis, what should we be looking for under, well, it says bandages, but compression gel?
Compression. I think in those, but it very much depends on whether you're using bandages or compression, garments, wraps. I think you need to be using something that allows you access to the limb to be able to look at the colour of the limb, whether the patient's getting any areas of soreness. And somebody, particularly in the early instances of using that compression, checking them very regularly, like you would if you were checking pressure areas, until you're sure that the patient's tolerating that. Again, looking for signs and symptoms of circulatory problems, yeah, colour changes, looking at the digits, capillary refill, things like that.
Okay, thank you. And someone's asked a question about what kind of bandage or compression can we use for swelling after orthopedic surgery. That's an issue that comes up every now and again for lymph in relation to orthopedics, but is there anything you'd like to comment on?
Yeah, I think it's, again, it's whether there's that double-edged sword, isn't there? It's that, do you use compression immediately post-surgery for post-op swelling? Or do you wait and then use it if the swelling doesn't go down? My personal opinion, not related to anything, any of my conflicts of interest, is that if I go for surgery, I'm in compression. And that helps with the post-op swelling, and it can be any of the normal compression that you'd use for that. So yeah.
I'm going to ask a related question that came up. We were talking earlier about if you wear compression and you're in hospital for a procedure for surgery,
Mhm.
should you wear your compression or should you wear the TED stockings that they want to give you?
Don't wear the TED stockings. Don't wear, keep to your prescribed compression. Quite often, if I have people who are going in for surgery, I'll order them some new stockings so that they've got new, fresh stockings for even if they're going to want them clean for when they're actually in theatre, and just really make um, the hospital aware that we've got the alert cards, the alert bands, that you've got lymphedema, and that, yeah, don't don't ever take anybody I know out of their compression because there'll be trouble.
Thanks very much. That's very clear. Somebody else is saying that they wear a compression bra each night, but their lymphedema spread from the breast round the back and down the front rib cage. Is there any other compression they can try besides kinetic or kinesio tape?
Yeah, I think there's lots out there, and again, it's discussing it with your therapist. One thing I would say though, that it may be that the bra you're using at night is not helping. Um, so yeah, it's that. Does it get worse when you take the bra off? Is that causing issues with twisting in bed? It's so difficult to tell without being assessed.
Yeah.
So there is a lot out there that can be used though.
But it sounds like other than trying not wearing it and seeing what happens,
Mm,
that this person should probably see someone about
yeah,
it. Yeah.
definitely. Definitely.
Okay, someone's asked a question about how often garments should be washed.
Well, how often would you wash your socks? Would be my response to that. I have clean socks every day. So we tend to get two sets of garments, one for wash, one for wear, and that you'd wash them on alternate days. But again, that will differ depending on what you're doing day to day. So yeah, it's how often do you wear them? If you're wearing something every day, then they should be washed every sort of other day.
Okay, thanks. A question from a therapist, but when edema has been present for a long time and turns fatty, how can we continue to reduce the volume as someone who's finding it difficult to get to a point where there's getting no further volume reduction, and
Mhm.
it's quite disappointing, upsetting for the patient because it's not improving anymore.
Yeah, it's a difficult one. There's some different schools of thought out there as regards fat, and actually some bits of research going on that are looking at using different treatment modalities to try and work with fat. But the only evidence-based thing that we've got at the moment for that is liposuction. So if you're getting no further reduction, then it's, yeah, looking at things like an MRI scan to quantify fat and fluid, and then the possibility of liposuction. The thing is with that though is it's just
Mhm.
we're not able to get it really on the NHS much anywhere.
Um, Someone's asking about tips to resolve situation when a flat knit length, high thigh length garment is gathering behind the knee.
All garments move, clothes move. You quite often, we will all be there on a daily basis adjusting our trousers or skirts or socks. So it's that thing of it it could be that it's just throughout the day things move. So using things like body glue to keep that garment in place a little bit more. I'd be checking the fit of the garment just to make sure that actually it is fitting. And it could be that edema's reduced and the garment's slipping. The other thing is a lot of the companies do anatomical zones around the knee that help. Nobody as much as garments are straight, nobody actually stands with their legs or has their arms completely straight. So using those anatomically flex zones might help. But again, checking the fit of everything and just making sure that it's appropriate still for that patient.
Okay. There's lots of questions coming in. I'm just trying to pick a variety. Should we be prescribing night compression for all patients?
I don't think it's individual. It's very individual. So I would say no.
Okay. And this is a little bit tricky. When is it necessary to get an ABPI prior to prescribing a leg garment?
Um, it, it depends on where you work. So for patients, and for those again that yeah, I can't say, Margaret, because it's either gold standard would be that everybody should have an ABPI. We know that that doesn't happen. And we know that actually you can safely apply compression in the absence of any of the red flags, um, as up to a class 1 garment. But again, it's that a patient should have some form of vascular assessment.
Yes. I think it's the revised British Lymphology Society guidance on assessing for vascular function should be out later this year. But I think we acknowledge that it can sometimes be difficult to get
Yeah.
an ABPI reading in somebody who's got lymphedema.
Yes.
You're absolutely right. That's not the only way of assessing them. They have to
Mhm.
have a thorough clinical assessment
Yeah.
to make sure it's as safe.
Yeah. And from a clinical perspective, because I'm aware we've sort of got a mix of people on this meeting today, but from a clinical perspective, if I've got somebody that comes in with a really large limb with lots of pitting edema, and we've ascertained what the cause is, we've ruled out any red flags, they're going straight into full compression for me, because we have got to get through thickened tissues, thickened skin, edema, fat. And you saw from my the MRI slides, that actually, because we've got big circumferences, we need to be able to get the pressure on. So, but that's me as a clinical specialist, and I will willingly sign to say I've done that.
Mhm.
We've got to work within the remit of what we're allowed to work in. Yeah.
Yeah. Um, is there ever a time when you advise someone not to wear compression for exercise apart from swimming?
Yeah. Yes. And
And
again, it's very, very individualized. If some patients will find that compression will make their lymphedema worse while they're doing certain things. So it's about titration, and it's about what plan we work for that individual. And I would rather somebody do their exercise than let compression stop them exercising.
I think the research by Karen Johansson showed that um, I think patients who wear compression normally could not wear them for exercise, but should observe for the next 24
Yeah.
hours, and often came down automatically. So I
Mhm.
think it's just learning about your own lymphedema.
Absolutely. And
But
listening to your body.
the other part of that question was apart from swimming, but I think we would say is you don't have to wear it for swimming
No.
because there is a compressive effect of the
Mhm.
pressure. So,
Yeah, definitely.
so I hope that's answered the question, whoever answered it. Um, uh, if a patient cannot wear compression, should they still be reviewed in the lymphedema clinic when it's the mainstay of treatment?
Yes, they should, because there are other modalities of treatment. And there are times where I have people that are unable to use graduated compression, but will use pneumatic compression pumps as their management, or kinesio tape, or have very, very regular lymphatic drainage. So I still think we should monitor them. And I think as well, compression changes, what's available changes.
Yes.
So it might be that some other miracle comes becomes available.
Okay. Um, there's a question after lipo, and I think it might be liposuction. Are patients in compression day and night?
Yes. 23 and a half hours a day, according to Hakan Brawson. However, again, it should be individualized. But I think if you're looking at going for liposuction for lymphedema, you have to be on board with 24-hour compression.
Okay, I'll just ask you one other question, Rachel, quite quick. Should compression garments be permanent for patients with lymphedema? And is a break recommended after a period of wearing these garments?
Okay. Again, you have to get to know your body. Quite often, yes, compression is lifelong. But there are instances, and again, it depends whether people have gone for surgery or things where a break from the compression is okay. And it's that thing of if you are on holiday and you are under a parasol with your legs elevated, then yeah, have a break from the compression or going to a wedding. You've just got to be able to know that actually, if the lymphedema does increase, that you can get it back reduced very quickly afterwards.
Yeah, it's all about it's common sense really, but I know people who have lymphedema will worry about not doing exactly as prescribed, but it is so individual, as you
Yes.
say, although we follow the same principles.
Yeah, it is.
Um, Now, there are a number of questions that we haven't been able to answer, but we're going to have to stop there. If we can answer them easily on text, we will do so. We'll try and follow up with some of them, but hopefully we've answered as many as possible. And if we've suggested that you see somebody, that you'll be able to do that. But thank you very much, Natalie.
Oh, thank you.
Thank you very much for everybody who's joined and all the questions. And I'd just like to end with one other thing about information for any practitioners, any healthcare professionals who are on who are maybe not lymphedema specialists and have joined us today. We do have a new, a free introduction to lymphedema study day that's we've put on this year to as partly to mark our 40th year of BLS, and it's going to be on the 6th of October at Chester Racecourse. It's designed to really equip people with knowledge and confidence to spot lymphedema early and give supportive care and collaborate with lymphedema specialists. So the link has just gone up, and we'll send it to you in a follow-up email if you want to find out about registering. But it is free, and hopefully that's something that's helpful if you want to join that. So tomorrow's session on Lymphedema Awareness Week is about lymphedema. Is it at risk after skin cancer? By Dr. Anusha Panthagani from the Derby and Nottingham National Centres. So if that's of interest for you, hopefully we'll see you there. But thank you once again, and hopefully that's been helpful. And
Thank
thank you.
you.